Hi, everybody, and welcome again to SCAI's Conversations in Interventional Cardiology. My name is Sahil Parikh from Columbia University Medical Center in New York City. I'm privileged to be one of the JSCAI associate editors, and I'm an associate professor of medicine here at Columbia, focusing on endovascular interventions. I'm really delighted to be here with two good friends and colleagues to talk about an interesting paper just published in JSCAI, which is entitled The Point of Care Ultrasound for the Detection of Vascular Access Site Complications, the ULTRASITCOM study. It's not a sitcom, it's actually serious stuff, and we're delighted to have the presenting author, Dr. Di Santo, from the faculty of the University of Ottawa and the Ottawa Hospital in Canada, and also my good friend, Dr. Carlos Mena-Hurtado, professor of medicine and co-director of the Vascular Outcomes Center at Yale, and one of the interventional cardiology faculty there. Carlos and I are both vascular medicine specialists and are delighted to see this being brought to the fore. So, Pietro, I'll turn over the podium, as it were, to you.
Thank you. Thank you very much. It's my distinct pleasure to be here with you to talk about our most recent publication from our group. And on behalf of all my co-authors, I do thank you guys for having us here. So as you alluded to, the title of the study is the ULTRASITCOM study. Just jumping right into things here, ultrasound is a versatile tool that's been used for diagnosing patients across a variety of different clinical environments, and its widespread use has been attributed to many distinct advantages, including high sensitivity, it's minimally invasive, it's overall fairly cost-effective. And recent technological progress has led to the miniaturization of these ultrasound components with improved battery life, high-resolution displays. And as the prices for these handheld devices have come down, particularly in the last decade, the accessibility of POCUS has moved far beyond the sort of confines of formal diagnostic imaging departments. And as many of us know, for many of our transcatheter procedures, vascular access complications remain the most common complication, including pseudoaneurysm formation, which is the focus of the ULTRASITCOM study. Importantly, these access site complications have been associated with many adverse outcomes, including things like increased hospital lengths of stay, patient morbidity and mortality, and even overall increase in healthcare costs. The poor diagnostic accuracy of physical examination has long been recognized in the detection of access site complications, and that has led to an increasing reliance from physicians and healthcare providers in the detection of these complications using formal diagnostic testing like ultrasound or CT. And the routine use of POCUS at the bedside has become really an established standard of care in other aspects of cardiovascular medicine, and therefore we sought to evaluate, what the ability of POCUS to detect vascular access complications following invasive cardiac procedures is. The study setup was such that it was a prospective diagnostic accuracy study conducted at a single quaternary care high-volume PCI center here in Canada. Participants were recruited over an 18-month period from February 2022 until September 2023. The study population included those patients that underwent invasive cardiac procedures and in whom there was a clinical suspicion of an access site complication. The assessments were performed by general cardiology and interventional cardiology fellows who had undergone a 2-hour training session with a vascular radiologist. And that training session really consisted of a didactic teaching session, as long as a case-based review of common pathologies that we see post-procedurally, with a focus on pseudoaneurysm. Once a patient was recruited in the study, they underwent a comprehensive physical exam by one of the trained fellows, followed by a POCUS assessment of the access site of concern. The results of their formal diagnostic testing was then reviewed to adjudicate true positive or not in terms of the outcomes of the point of care assessments compared to the formal diagnostic testing. And really, the primary outcome of our study was something known as the diagnostic odds ratio, which compared physical exam and POCUS assessment to formal diagnostic imaging. The diagnostic odds ratio is really defined as the ratio of the odds of a positive test when the patient has the disease compared to that relative to positive tests when they do not have the disease. In other words, it's the odds of a true positive relative to that of a false positive. And I think, it's important to take a moment to explain why we chose this as our outcome measure. And the diagnostic odds ratio is it's a singular value that is used to indicate overall test performance. The value of it, for those that are unfamiliar, ranges from 0 to infinity, with higher values indicating that there is improved discriminatory performance of the test. And a diagnostic odds ratio of 1 means that that the test does not discriminate, i.e., there's no difference between those with and without the disorder. And really, the main advantage of this diagnostic odds ratio is that it does not depend on the prevalence of the disease that the test is being used for, unlike things like negative and positive predictive values. And so we use this as our primary outcome measure in the study. Overall, there were 111 participants recruited. There were 3 patients, unfortunately, who did not undergo formal diagnostic testing, but that meant that over 97% of our patients did have a formal ultrasound or CT that we were able to compare to. About 60% of the patients were females with a mean age of 70 years of age, approximately. About a quarter of the patients underwent diagnostic coronary angiography. 50% of the patients had undergone PCI. 20% of the patients had undergone TAVR, and the remainder are kind of a hodgepodge of various invasive cardiovascular procedures. 2/3 of the patients had an access site concern of the femoral artery. Another third had about radial, and only 1 patient had a concern at the site of brachial access. The vast majority of sheaths used in this study were 6 French sheaths, and obviously the other 30% was a number of different sheath sizes, up to 14 French. And vascular closure devices were used in about 50% of the patients, and that's kind of overall. That includes radial and femoral procedures that were performed, but suture-based or collagen-based suture vascular closure devices were used in about half of the patients. And in these 108 patients, there was a confirmed pseudoaneurysm in 15 of the patients, 9 of which were transfemoral and 6 were transradial. And really what we were able to see was that the diagnostic odds ratio for the detection of pseudoaneurysm was greater with the combined POCUS assessment compared to that of physical examination alone. So 42.6%, 42.6 odds versus 15.6, and with a p-value of less than 0.01 between those two components. And really, the other thing to note is that there's a fairly high sensitivity of 93% when you're adding POCUS, which provides an incremental benefit over physical exam alone by a fairly substantial amount, certainly clinically significant, 80% with physical exam only versus 93% when you add on the POCUS assessment. And I think to the best of my knowledge, this study is the first to use POCUS for the detection of vascular access complications. And I think based on the study results, one can envision POCUS becoming a standard of care and really at least a standardized part of interventional training to enable sort of timely interventions. And who knows, maybe that could potentially reduce even morbidity and healthcare costs. Certainly that was beyond the scope of this study in and of itself. But I think as a proof of concept, the use of POCUS for access site complications is really supported by our 3 main findings. And, firstly, the diagnostic performance overall through that diagnostic odds ratio value being quite high in this post-procedure population suggests an overall strong performance of the test. Secondly, the sensitivity of the POCUS assessments was very high at 93% and a negative predictive value of 98%, suggesting that a negative study was reassuring to rule out pseudoaneurysm. And thirdly, the cardiology fellows only had a 2-hour didactic training session with no further hands-on training, suggesting that there is an opportunity for a rapid acquisition of the skill set necessary to perform these assessments. And overall, even though the performance of POCUS is already quite good as demonstrated in the study, I can certainly envision that with even more experience and training, interventional cardiologists and fellows might be able to attain diagnostic accuracy approaching that of formal studies. And therefore, I do think that, this should be something that should be highlighted in training programs quite broadly, and certainly as you will, I'm sure, both speak of as interventional cardiology does do a lot of peripheral vascular interventions. This is certainly something that I think could be well within our scope of practice. That's all I had to say about the study. Thanks for having me.
Pietro, that was a great review of the data. Thank you. And Carlos, I want to give you a first crack. Give me your impressions. Is this consistent with what you would have expected? Do you think that the diagnostic accuracy is sufficient in the hands of the everyman interventionalist to use this more effectively for post procedural complication assessment?
Thank you, Sahil, and Pietro, thank you. I agree it's an important study and certainly changes a little bit the way we see ultrasound. When Sahil and I were in training, we were doing blind sticks, and then data emerged that actually doing with ultrasound guided lessened the complications that they were having. Now you are giving it another dimension and is added in the diagnosis of potential complications after the interventions that we do. I think it's incredibly useful. I was impacted by the fact that the fellows were doing the study and only 2 hours of training. So it's not that time consuming and demanding, and it really will change the way you treat the patient, how effectively you treat them, and the timing of the intervention. I do have one quick question, if I may. What was the timing between the procedure and the ultrasound done by the fellow?
That data is not specifically recorded. Anecdotally, as you alluded to, this was a fellow-led project, and actually I completed this during my fellowship. Anecdotally, the time from initial procedure or post-procedural assessment to the POCUS is being performed by the fellows was very short. Generally, within a couple of hours, I would say, these scans were being done.
Which is also very important because some of the limitations, and I'm sure Sahil at Columbia experienced the same, there is marked delay to getting a formal ultrasound, and having the ability to do it right away when there is a clinical suspicion of a complication enhances your ability to do interventions. So overall, I think that is an important finding that you're presenting us tonight.
So Pietro, did you find any AV fistulae, or it was just all pseudoaneurysms?
So the way the study was designed, we really wanted to focus on pseudoaneurysms as they're the complication that, it was something that we dread kind of the most post-vascular access, and we wanted to screen for kind of the most clinically significant or important potential complication. Part of the study did involve assessing for other pathologies, and the didactic training session that was given to us did include various pathologies, including just even assessments of plain old hematomas. What does that look like? How do you distinguish that from a pseudoaneurysm, from AV fistulas, et cetera? We did look at AV fistulas. We even looked at, as a bit of an aside, also screening for thromboses like DVTs post-procedure and this sort of thing, if it had been predominantly venous access, for example, in a mitral clip or something like that. And so we did look for them. There was a few AV fistulas that were detected, again, beyond the scope of what was presented here. But I think the overall study message is that you can fairly quickly and with fairly high fidelity train fellows that are already well versed, as Carlos has already mentioned. We do use this pre-procedurally quite often. We're quite comfortable with it pre. Maybe this is another dimension, maybe something that we can add on after the fact to further enhance our ability to make these diagnoses in a bit more of a time-effective manner.
Great. I mean, I think that we would agree. Carlos and I use ultrasound routinely for a host of things. We're all certified in reading vascular ultrasound. Those of us that do this, on a regular basis. But for the average interventionist, the advent of ultrasound guided access has taken some time to sort of become the mainstay. I think this is, as Carlos pointed out perfectly, it's another dimension of the value of being facile in doing diagnostic ultrasound. In many of these cases, the pseudoaneurysm seems small and might have been amenable to ultrasound-guided compression, which could be done right away, avoiding a hospital length of stay and improving patient comfort and outcome. I think the other key point is that in order to do this, you need very simple equipment. But for sure, it's not just 2D imaging. You had color flow. I'm sure Doppler in all of the cases. What are the bare minimums for vascular access that you guys recommend in terms of ultrasound? First, Pietro, then Carlos. I'm curious to see what kind of equipment do we need.
I agree with you. I mean, I think the take-home message is that, in order to do a vascular assessment, you actually need fairly little. This was really based on 2D images and color Doppler images. It wasn't, we weren't necessarily required to, PW across a neck to look at velocities and look at this sort of things. It was really a qualitative assessment of the potential complication. 2D images, color Doppler. Do you think there's a problem? Yes or no? And I think as a screening approach, and certainly, based on the results of this study, our center has actually become a lot more aggressive with things like POCUS in the post-procedural evaluation. And if we're fairly confident with our combination of physical assessment plus the POCUS assessment that we're doing at the bedside, we're pretty comfortable to actually not pursue formalized imaging. And so I think, I don't think you need very much to answer your question. I think you need 2D and color Doppler.
I would agree with that. I think that the question that comes up, though, as I was asking you earlier, is the timing. Because as Sahil mentioned, many times after the procedure, whether you use a closure device or manual compression, you may have some extravasation that may or not look like a pseudoaneurysm right on ultrasound right after. So is it right after the procedure? Is it 2 hours? Is it 4 hours? Does that change the management in terms of an intervention afterwards or not? I think that those are the follow-up questions that come naturally after the study that you just presented us.
Yeah, that's a great point, Carlos. I mean, I think if you guys in your next phase of this study, if you were to protocolize that, you'd probably get a good sense. Many of the smaller pseudos are going to go away, so to speak, right, the longer it is from time to hemostasis. But the ones that are persistent are the problems, and albeit a rare complication, it makes sense to have it diagnosed on the spot and potentially even addressed with a clinical treatment on the spot, whether it's thrombin injection or ultrasound guided compression or whatever other modality.
Yeah. And lastly, the one other thing that I was curious is that whether you guys look at in your data any predictors of those vascular complications. In other words, those that did have the pseudoaneurysms, you mentioned about 15% of them. Were there any elements, whether pre-intervention or during the intervention, that made them more likely to have that complication? That would be important to know. So we learn more about this.
For sure. I think it's, we did not formally look at, statistical probabilities of predictors of these outcomes, of the outcome. But certainly something that we'd be happy to go back and take a look at and see if we can find, what are these highest risk patients and what was common amongst them. And, how do we, better manage those particularly high risk patients?
Right.
Well, I think, Pietro, thank you first for presenting the data, and we're delighted that it's in JSCAI. I think it should give all interventional cardiologists who practice femoral access a little bit of pause, because the access can always be the most humbling part of the case, and it's often what the patient remembers the most afterwards. And in an era where radial access is so common, it was interesting to see that you had pseudoaneurysms in a higher than expected proportion of radial access patients. And frequently when we do femoral access these days, it's always for large bore, which, as we know, is higher risk. So I think all of these facts make it more compelling that we should be doing some sort of formal ultrasound training in our training programs, and probably some remedial training for those of us faculty who are old enough to remember when we were just sticking the groin blind. So I think that's really critical. Carlos, I'll give you the last word. Any parting shots?
No, I think that it's an evolving field. We got to continue looking at it and help us to improve the outcomes in all these interventions.
Well, I thank you. And Pietro, thank you and your team in Ottawa. It should be an inspiration for all fellows that they can make a meaningful contribution as a group, answering important bedside questions with simple clinical observations. So on behalf of JSCAI and the editors, thank you for joining us. Please look out for the article on jsky.org. Thanks so much.